supporting Suki as she checks off on the cardiovascular system. It's Sunday, October 20th, 3:56, and your 10 minutes start now.
Okay, so coming in, I can see that patient has no JVDs. There are no apparent excess pulsations. Can I lie down real quick? Sorry. And just gonna look at your stomach, not really your stomach. So there's no real pulsations there either. Alright, you can sit back up real quick. Okay, and then so I'm just gonna feel around your heart spaces to assess the precordium. I'm gonna look right around here. Sorry. Okay, so there's no extra vibrations or pulsations. The skin seems pretty clear and free of lesions. I'm just going to listen to a couple sounds. I would be listening with the diaphragm and the stethoscope for normal sounds and the bell for unusual sounds like a murmur. The first place I'm going to listen to is your aortic site, which is at the second intercostal space on the right sternal border. So that would be your right. So that would be one, two. Okay, and then on the right or left sternal border, second intercostal space is the pulmonic. Okay, and then third intercostal space, right sternal border, that's Erb's point. That's the place where you can hear S1 and S2 the best. So right here. Cool. And then sorry, the tricuspid. Here, I'm gonna push it a little bit. Tricuspid is at the fourth intercostal space, left sternal border as well. So here. And then mitral right here. Okay, perfect. You can shut your phone. So at Erb's point, where you can hear S1 and S2 the best, that's because it's kind of right in the middle of everything. S1 is the sound of the ventricles, those valves closing. S2 is the atrial sounds, the atrial valves closing. If I were to hear S3, it would be an extra ventricular sound, and S4 would be an extra atrial sound. The mitral valve is also the point of maximal impulse, so I'm just going to feel around there again. Sorry, borrow your skin again. So right around here, it would be the strongest place where I could hear the, okay, so it's right about here. It's about the width of my fingertip, and you can hear it, you can feel it really well. It's a little bit stronger. Okay, so I'm just going to assess your blood vessels real quick, your pulses. So the first place, you just relax. You have the temporal. Okay, and then here I'm only going to assess one at a time, because I don't want to harass you. And normally you'd be assessing for symmetry, because you'd want to cut off the blood supply there, that would be bad. So I can't assess your radial pulses symmetrically, but here, this one I can feel. And then I would move up to the brachial, since I can't feel your other radial. Okay, and you can feel the brachial pulse here, and also lower. I could also assess the axillary and femoral pulses, but that's a little invasive, so I'm not going to do that. So pop his heel behind your knee. Okay. Good. Okay, I'm going to borrow your shoes. Take your shoes off real quick. Sorry, should have had you do that earlier. Sorry. Okay. Okay, so the posterior tibialis is right here on the inside behind that malleolus. Good. And then your dorsalis pedis is right here. And there. Cool. Okay. So your pulses are pretty symmetrical. I can feel them in all the areas, so that's a good sign. If I couldn't find one distally, I could always move proximally because it's always going to, if there was to be an incident of trauma or something like that, the areas would shut down distally or proximally. Test your capillary refill. Good. That foot's really cold. Okay, and then this one. So that's a rapid refill. That's really good too. And to assess for any JVDs, I would have you stretch out your foot here, and then I would flex it back. Did you feel any pain? Okay. Let's just relax here, and then did you feel anything here? Okay. That's good. Okay. Last thing I'm going to do is take your blood pressure. Can I just scoot this way a little bit, just so I'll get the side and not squeeze your cast. Okay, so I'm going to assess for an oscillatory gap, so I'm going to inflate the cuff. I don't need to do it again. Inflate the cuff really slowly first. Or this side. Fine. Just more along. Sorry, I dropped that on you. Okay, so I stopped hearing the pulse, so I'm going to move it up a little bit higher, about 20. Okay, and I still can't hear it, so I'm going to let you go for a second. And what I was doing is, when you get to a certain point, you can stop hearing the pulse. And some people have what's called an oscillatory gap, so if you were able to hear it at a higher rate, it's just, a lot of people miss that because they stop when they can't hear it anymore. And then, alright, you all free? I can feel a little faster now because I already know where that is. Go. Okay. So that was good. It was about 119 over 68, so it's definitely within a normal range. Let's see if I missed anything. Oh, when I was listening to your, I never listened for a minute. Do that real quick. Okay, so using the bill of my stethoscope. So going back to the same spots to listen for any murmur. A nice hard key. Okay. Okay. So I didn't see or hear any murmurs, and I didn't see or feel any heaves, lifts, thrusts, or thrills, which would be visual or physical, like tactile evidence of a murmur, but I didn't find any of that. So I think that's pretty much it. So.